short-term and some long-term complications of premature birth. Why betamethasone administration is important. Here are some of the major risks and challenges premature infants might face. Respiratory distress syndrome, RDS, intraventricular hemorrhage, IVH, which is a bleeding in the brain. We talked about lungs, we talked about brain. Let's talk about gastrointestinal tract and gastrointestinal difficulties. Welcome, Dr. Anita Stola. Today, very important topic, short-term and some long-term complications of premature birth. Prematurity is defined as birth occurring before 37 weeks of gestation. It is associated with range of risk and complications that can affect nearly every system in newborn's body. The degree of risk generally correlates with how early a baby is born. The earlier the birth, the higher the risk of complications. Before discussing risk and complications of prematurity, I wanted to briefly mention about importance of steroids, medication that is called betamethasone, when we do expect premature delivery. The administration of steroids for women at risk of premature delivery is a critical medical intervention that has significant benefits for the newborn. Betamethasone is a corticosteroid medication that is highly important in the management of premature labor, especially when there is a risk of premature delivery. Its primary role is to promote lung maturation of the lung, fetus's lung, which is crucial for newborns who might otherwise struggle with respiratory problems after birth. Why betamethasone administration is important? Number one, lung maturation, as we already mentioned. Betamethasone accelerates the production of surfactant, a substance that lines the surface of air sacs in the lungs to prevent their collapse upon exhalation. Surfactant is like a soap, like a film that is coating our lungs and keeps air sacs open. Babies don't have enough of that surfactant soap thing in their lungs until they are about 34 weeks of gestation. Betamethasone, that medication that is given to mom, increases production of surfactant by air sacs, making baby's lungs more mature by that. Number two, what's the other action of benefit of betamethasone? Beyond lung maturation, betamethasone may also help mature other vital organs and systems in premature infants, reducing the severity of complications and improving overall survival rates. Administering of betamethasone to mother can reduce the incidence of several severe complications associated with premature birth, such as intraventricular hemorrhage, which is bleeding in the brain, or necrotizing enterocolitis, which is a serious intestinal problem disease, or systemic infections in the first 48 hours of life, or betamethasone can even reduce the infant's death, rate of death. These benefits collectively improve the survival rates and health. What is the route of administration of betamethasone? This medication is typically given intramuscularly, which means that it's injected to a muscle. This route helps in the slow and steady absorption of the drug into the bloodstream. Betamethasone is usually administered when preterm delivery is considered likely within the next 7 days. It is usually given as 2 injections 24 hours apart, and the benefits are maximized if the delivery occurs between 24 hours and 7 days after the last dose. Betamethasone is most effective also when it's given between 24 and 34 weeks of gestation. However, it can be given earlier than 24 weeks or slightly later than 34 weeks in some cases, depending on the specific medical situation. Do we repeat betamethasone courses? It may be considered if initial course was given more than 7 days before delivery and the risk of preterm birth remains high. However, the decision to administer additional courses should be made on case-by-case basis as the evidence for safety and efficacy of repeat courses is less clear. Now let's talk about complications of prematurity. Here are some of the major risks and challenges premature infants might face. Number one, the big one, respiratory problems. Premature babies often have underdeveloped lungs. They may suffer from respiratory distress syndrome, RDS, which occurs when the baby's lungs can't provide their body with enough oxygen. RDS, respiratory distress syndrome, is also known as hyaline membrane disease. It primarily affects premature infants born before 34 weeks of gestation, as their lungs have not produced enough surfactant of that soap thick. Surfactant is a critical substance that keeps the air sacs in the lungs open, allowing for the exchange of oxygen and carbon dioxide. Without sufficient surfactant, the air sacs collapse, leading to breathing difficulties. What is the treatment of RDS? Number one, it may be surfactant replacement therapy. Sometimes it's necessary to administer surfactant directly to baby's lungs through something that is called breathing tube. It's a plastic tube that we put in the breathing pipe. Number two, mechanical ventilation. Sometimes we have to use machine that it's called CPAP, continuous positive airway pressure. It's a machine that delivers air to baby's lungs through the mask that goes around baby's nose. It blows some air and oxygen to the lungs and keeps the air sacs open. The next respiratory problem that babies in the NICU may encounter, premature babies, it's called bronchopulmonary dysplasia, BPD. That's another concern, a chronic lung condition that can develop in infants who need long-term respiratory support. BPD, it's a chronic lung condition that can develop following RDS, particularly in infants who have required prolonged mechanical ventilation and prolonged oxygen therapy. The high levels of oxygen and pressure required to treat RDS can also unfortunately damage the delicate tissue of the lungs, leading to inflammation and scarring in the lungs. This condition affects how well the lungs can transfer oxygen into the bloodstream and remove carbon dioxide from the blood. Management strategies for BPD include, number one, reduce oxygen use, careful managing oxygen therapy to the minimum required to maintain sufficient blood oxygen levels without causing further damage. Number two, sometimes we have to use diuretics. This is a medication that helps to remove excess fluid from baby's lungs. And number three, inhaled, oral or intravenous corticosteroids to reduce inflammation in baby's lungs. Respiratory problems are among the most common and serious issues facing premature infants due to their underdeveloped lungs and respiratory system. And these problems vary in severity depending on how early the baby was born and other individual health factors. Number three, in regards to respiratory problems in newborn babies, apnea of prematurity. Apnea is a common condition in premature infants that is characterized by pauses in breathing for 15 seconds or more. This can occur due to the immaturity of brain's respiratory center, which regulates breathing. Treatment of apnea of prematurity includes stimulation, gentle tactile stimulation to prompt breathing, caffeine therapy, which may be oral or intravenous that is administered to stimulate breathing. Caffeine also strengthens the diaphragm, which is a big and strong muscle that separates our chest from abdominal cavity. In more severe cases of apnea of prematurity, sometimes mechanical support may be required, CPAP or ventilator, in order to assist the baby breathing until the respiratory drive matures. And finally, the third pulmonary lung complication is something that is called pulmonary hemorrhage. This is the less common but severe complications where bleeding occurs into baby's lungs. It can be related to pre-existing conditions like severe RDS or infection or some heart defects. Treatment of pulmonary hemorrhage focuses on supporting the baby's breathing and may include blood transfusion and other intensive care measures. Let's move to the next organ, next system, neurological issues. The earlier a baby is born, the higher the risk for neurological complications. These can include intraventricular hemorrhage, IVH, which is a bleeding in the brain. Premature infants are also at higher risk for developmental delays and may have problems with learning, motor skills, and coordination as they grow older. Intraventricular hemorrhage, IVH, is a significant concern in premature infants, particularly those born very premature. This condition involves bleeding into brain's ventricular system, where the cerebrospinal fluid is produced and stored. IVH is most common in the first 72 hours after birth and occurs more frequently in infants born before 32 weeks of gestation or weighing less than 1,500 grams. Now, grades of IVH, there is 4 of them. They are classified according to the severity. Grade 1, bleeding occurs just in the lining of the ventricles. Grade 2, bleeding also occurs inside the ventricle, but they are not enlarged. Grade 3, there is so much blood in the ventricle that ventricles are enlarged. And finally, grade 4, bleeding extends from the ventricle also to brain tissue around the ventricles. Grade 1 and 2 intraventricular hemorrhage, those are less severe and often resolve with minimal long-term impact, but grade 3 or 4 are associated with higher risk of significant neurological damage. What are the causes and risk factors of intraventricular hemorrhage? The exact cause of IVH is not entirely understood, but it's believed to be due to the fragility of the blood vessels in premature infant's brain. These vessels can easily rupture. They are very weak, fragile, and they rupture under stress, from example, changes in the blood pressure, or any instability in infant's condition can cause those vessels to rupture and cause bleeding. Risk factors include prematurity, especially births before 32 weeks of gestation. Respiratory distress syndrome is a risk factor. Fluctuation in the blood pressure related to breathing problems can contribute to IVH. Then blood pressure instability, both very high and low blood pressure can be risk factors for that intraventricular bleeding. Big one, pneumothorax, air leaks into the chest outside of the lungs can increase significantly the risk of Diagnosis and monitoring of IVH is usually confirmed through ultrasound scans of the head, which can, through the soft spot, that can visualize the brain's ventricles and detect any bleeding. This is a non-invasive procedure, and it's often performed routinely in the first few days, a week after birth for very premature infants. Ongoing monitoring may include repeat scans, ultrasounds of the head through the soft spot to observe progression of the hemorrhage and assess the need for eventual further intervention. Unfortunately, there is no direct treatment to stop the bleeding once intraventricular hemorrhage has occurred. The care of infant is focused on managing symptoms and preventing complications. Long-term outcomes depend on the severity of the bleeding. Lower grades of IVH may result in minimal or no permanent damage, while the higher grades, grade 3 and 4, can lead to complications such as hydrocephalus, which is excessive accumulation of cerebrospinal fluid in the brain, or cerebral palsy, cognitive impairments, and other developmental delays. We talked about lungs, we talked about brain. Let's talk about gastrointestinal tract and gastrointestinal difficulties. Prematurity can affect the development of baby's gastrointestinal system. Number one problem, necrotizing enterocolitis. It is a serious intestinal problem that affects some premature infants and involves infection and inflammation that can cause destruction of the bowel tissue. Early diagnosis and treatment are critical to manage this condition. Number two, feeding difficulties in premature infants. Very common problem. Premature babies have high nutritional needs for growth and development, but often struggle to consume enough calories because of their small size and reduced oxygen due to medical complications. They require more calories, more proteins, more vitamins and minerals per pound of the body weight than full-term babies. Managing these needs often involves fortified breast milk or formula. Breast milk, while it is the best source of nutrition for most infants, may not contain sufficient nutrients for premature babies. It is often fortified with additional proteins, calories, and minerals. There are also special premature formulas when the breast milk is not available. Formulas specially designed for premature infants can be used. These formulas are richer in calories, in nutrients, calcium, phosphorus that are essential for baby's growth. Now, feeding difficulties and feeding methods. Premature babies may not be able to breastfeed or bottle feed effectively. They need to learn how to suck, how to nipple. They learn how to do it the same way as babies learn how to walk. Babies know how to suck, how to nipple when they are about 34-35 weeks of gestation. Babies also need to learn suck, swallow, and breathe coordination. For us adults, it's automatic reflex. For babies, this becomes kind of automatic when they are approximately 38 weeks of corrected gestational age. In case the baby is born very prematurely, obviously we cannot start to feed them with large volumes right away. Their GI tract needs to get used to enteral feedings, and that is why some alternative feeding methods are often necessary in those premature babies. And those are intravenous IV nutrition, also known as total parenteral nutrition, TPN. This is used when the baby cannot feed by mouth, or in case of the extreme prematurity, when we need to start initially with small enteral feeding volumes. And then we have to support the baby also with that IV TPN nutrition as well. Nutrients, glucose, protein, fat, vitamin, microelements are provided directly into the baby's vein to ensure that the infant receives all necessary nutrients. As I mentioned, because babies don't know how to suck out the nipple before 34-35 weeks of gestation, we have to feed them initially through something that's called gavage feeding tube. It's a plastic tube, small, that is passed through the nose, baby's nose or mouth into their stomach, and we deliver through that tube either breast milk or formula when the baby is unable or does not know how to feed by sucking effectively. Feeding is not just a nutritional issue, but also an important developmental activity for infants. It helps in the development of muscles and nerves in the face and oral cavity, which are important for speech and facial development. Delays in feeding can affect these areas. Those babies may have oral aversion. Some premature infants develop an aversion to feeding by mouth due to prolonged periods of tube feeding, unpleasant experience with feeding, or associated discomfort. Motor skills development, coordination of sucking, swallowing, and breathing, it's a crucial and can be delayed in premature infants, requiring some intervention from specialists such as speech and language therapists or occupational therapies. The next affected system in newborn babies is immune system. Babies have much less mature immune system, making them more susceptible to infection. In case of premature labor, because baby's immature system, they cannot fight infection the way that we adults can do, we do treat those premature babies with IV antibiotics. Premature labor itself may be first signs, symptoms of infection in a mom and in a baby. Mom's adult and mature immune system can't fight infection without any problem. Sometimes mom may not even have any symptoms. Whatever is not dangerous to mom, it may be very dangerous to her baby, premature baby, because again of immature and weak immune system. On admission to neonatal ICU, we do obtain a blood test to check for infection, and we usually start 2 intravenous antibiotics. If test results come back negative, reassuring, we stop antibiotics after 36 hours. Why is it 36 hours? This is the time for the test results to come back and reassure us that there is no bacteria that could cause any infection in a baby. Next complication. Let's move to hypothermia. Premature babies may also struggle with maintaining body temperature, leading to additional complications such as hypothermia, which can exacerbate other health issues. Why premature babies are at risk of hypothermia? Number one, they have reduced body fat. Premature babies have less body fat, especially brown fat, which is crucial for thermogenesis, which is a heat production in the body. This makes it difficult for them to maintain their body temperature. Number two, they have underdeveloped skin. The skin of premature infants is thinner and less mature, leading to higher rates of heat loss through the skin. And number three, lower muscle mass. There is less muscle mass that reduces the baby's ability to generate heat through the muscle activity. And there is number four, inefficient physiologic responses. The normal response to cold, like shivering or vasoconstriction, which is a narrowing of the blood vessels, are poorly developed in premature infants. Hypothermia in premature babies can lead to several serious health complications like increased energy expenditure. Maintaining body temperature in cold environments require energy, which can deplete the energy needed for growth and recovery. It can also cause respiratory problems. Hypothermia can exacerbate respiratory issues, making it harder for premature babies to breathe. Hypothermia can cause hypoglycemia, which is a low blood sugar, decreased glucose levels because of increased glucose consumption for heat production. It can also cause something that it's called metabolic acidosis. Hypothermia can disturb the acid-base balance in the infant's body, leading to metabolic acidosis. And finally, increased risk of infection. A lower body temperature can impair the immune response, making infants more susceptible to infection. To prevent and manage hypothermia in premature infants, we use several strategies. Thermal environment control, maintaining optimal thermal environment in neonatal intensive care units. It's critical. This includes the use incubators, so that plastic house that the baby is going to live in for some time, radiant warmers, and controlled room temperature. Then skin-to-skin contact, that's very important, also known as kangaroo care. This involves direct contact between the baby's skin and the parent's skin. It's an effective way to improve thermoregulation, along with enhancing bonding and breastfeeding. Continuous monitoring of body temperature using digital thermometers or skin probes helps in early detection of hypothermia. Let's move to the next system in premature infants, cardiovascular system and cardiovascular instability. Patent ductus arteriosus, PDA. It's a common heart condition among premature infants, occurring when the ductus arteriosus, a blood vessel in the heart, fails to close after birth. The ductus arteriosus is a normal fetal blood vessel that connects pulmonary artery to the aorta, bypassing baby's lungs. Before birth, this vessel is essential because the fetus gets oxygen from maternal placental vessels, not from its own lungs. Everything is filled with fluids and babies are not breathing in utero. At birth, as the baby takes first breath, the lungs begin to function and the ductus arteriosus, that small vessel, is supposed to close within first 24 to 48 hours to ensure blood flows properly through the heart and lungs. In full-term infants, the ductus arteriosus typically closes naturally soon after birth. However, in premature infants, this closure may not occur, leading to a PDA, something that is called PDA, patent ductus arteriosus. The persistence of ductus arteriosus can significantly affect the baby's circulation and heart function. Symptoms of PDA, patent ductus arteriosus, may include rapid breathing. Those babies that have patent ductus arteriosus may need more support and more oxygen to support their breathing. Then rapid fast heart rate. They have poor feeding tolerance and poor growth. Next organ that can be affected in premature babies is eye, and here we need to talk about ROP, retinopathy of prematurity. This condition occurs when abnormal blood vessels grow in the retina, which is the layer of tissue that at the back of the eye. Retina is a light-sensitive part of the eye, and these vessels are not fully developed in retina in premature babies and may grow abnormally. ROP can cause vision problems, and in severe cases, it can cause blindness. ROP is particularly common in those babies that are born before 31 weeks of gestation, or birth weight is less than 1250 grams at birth. The development of ROP is closely linked to the use of supplemental oxygen in the NICU neonatal ICU. While oxygen is crucial for the survival of premature babies, its excessive use can contribute to abnormal retinal vascular growth. ROP is classified to 5 stages, ranging from mild, which is stage 1, to severe, stage 5. Because the initial stages of ROP often present with no symptoms, regular eye exam while the babies in the NICU are critical for infants at risk. These exams usually begin 4-6 weeks after baby is born and are conducted using an instrument that is called ophthalmoscope. The frequency of these screenings depend on the initial findings and the infant's health. And finally, the last topic to discuss is long-term developmental outcomes. Premature babies are at increased risk for long-term intellectual and developmental disabilities. The earliest baby is born significantly influences the risk and severity of developmental issues. Premature infants are at increased risk of cognitive impairments compared to full-term babies. This may manifest as difficulties in learning, memory, attention, and problem-solving skills. Motor development may be also affected by prematurity. Delays in reaching motor milestones such as sitting up, crawling, and walking. Premature babies are also at risk of cerebral palsy, especially those babies that are born very early or with very low birth weight. Premature babies have also higher rates of behavioral and emotional problems. Diseases such as ADHD, attention deficit hyperactivity disorder, anxiety, and social difficulties are more common in premature babies. It's important to stress out here that early intervention programs and therapies such as physical therapy, occupational therapy, speech therapy are crucial for improving those outcomes. Each baby, each child is unique, and while some may experience significant challenges, others may catch up with their full-term peer and show minimal developmental issues. To summarize, antenatal interventions such as corticosteroids given to the mother before birth can help mature the baby's lungs. After birth, maintaining a sterile environment, careful monitoring, and appropriate medical care are essential to manage and mitigate the risk associated with prematurity. Managing the health of premature infant requires a comprehensive and multidisciplinary approach involving neonatologists, nurses, and a range of therapists. With advances in medical science, the outcomes for premature infants continue to improve, although the risk and challenges remain significant. If there is any questions, any concerns, please do not hesitate to contact me at neonatologyforparents.com. Thank you.